This
Thanks for the
meeting is
reminder.
being recorded.
Excellent. So I'll hand this over to Dr. Oliveira, and I'll let you kind of introduce yourself. And we're probably going to give each of you about 20 to 25 minutes. It's up to you as far as if you want Q&A during or you want to wait until after.
Okay.
That's there, but I'll hand it over. And just one more reminder too, to please mute your at your site so that there's no background noise.
Okay. All right. My name is Juliana Oliveira. I'm a family medicine physician at a community health clinic north of Seattle, and we're a community health clinic that serves primarily a Latino patient population. It was actually, I forget how long ago the clinic organization was started, but it was started to treat Latino populations in the Seattle area, and it's since expanded to all underserved populations and all the refugee populations in this area, but we still primarily serve Latino populations. And forgive me, guys, this is my first time doing this, and I'm relatively new in my career. I just finished my residency about, I guess, 6 months ago now, and I've just started working with this organization. But it's been a lot of learning for me, especially working with this Latino patient population. So I wanted to talk to you guys a little bit more about it, because I think Tyler Lawrence, who's in this webinar, he works at my clinic, and I think with the patients that we serve, who are mostly immigrants, a lot of them have come over seeking asylum, or have spent time in detention centers trying to cross over into the United States from Mexico or Central America. And then we also have patients who have been here for 15, 20 years, but all of them kind of share similar stories and similar thoughts about healthcare and just life in general. So I've learned a lot, and I'd like to share that with you guys, because I think that as the immigrant crisis continues, and just we continue to have more immigrants, especially Latino immigrants in this country, that behavioral health is going to play such an important role in the total health of these patient populations. And I just wanted to kind of bring up a discussion with you guys about today about how to kind of address these patients and how to work with them. And I think you guys will, behavioral therapists and psychiatrists and psychologists, will all play huge role in helping me provide good primary care to these patients. But so just as kind of a background, one of the reasons I think my topic was the role of kind of family members in providing care in Latino populations. And I don't want to overlap too much with the next provider, but I did focus a little bit on translating. And that's because what I found is that I learned in my residency, it's always that healthcare experts tend to say that it's not advisable to use untrained interpreters as or even medical office staff members or family members as translators, but that's not at all the case that I found in my practice. And granted, I'm a primary care physician. I'm usually not giving devastating news. I'm never consenting patients to tremendous surgeries or anything that's usually life-threatening. I provide basic care, and with my Latino patient populations, I actually provide there's a lot of depression and a lot of just underlying psychiatric disease. And I have found in my practice that involving the family, whether it's having them in the room all together and discussing issues, or having families directly translate for my patients, sometimes has allowed me to have better results and just connect better to my patients. Also, the one thing that I've found here, especially in our clinic, is that our MAs, the majority of them are Latino. Most of them are Mexican. There's one that's Nicaraguan, but they match up with our patient population, and they share similarities, either whether it's cultural background or if they're from similar towns or similar experiences as our patients. And they are a huge, huge asset to our clinic, because they help me especially connect to my patients. And they've taught me a lot about Hispanic and Latino culture, and just the plight that our patients go through to get to the United States, to get to come see me. And it's really, I think, helped me provide better care for them. So just a few things I wanted to talk about is that, so with a lot of these patients that you see, I think I've started to refer them a lot more to behavioral health and behavioral counseling. I see so many Latino patients who come in and they're complaining of generalized aches and pains or fatigue, and it's all underlying depression and underlying anxiety. And a lot of that is due to the cultural shifts that they've had to come through and the stresses that they're coming to. Imagine you come to a new country and you can't speak the language. A lot of my patients will come see me and they've just come to the United States and they still don't know where their family members are. And it takes a few visits usually, starting by addressing their aches and pains and their complaints of fatigue. And then you do realize that a lot of it is just underlying anxiety and depression. And then you guys, the behavioral therapists, would come in as a help to me. And I guess part of this is that what I found is that the times that I'm able to really uncover and ask questions about the anxiety and depression and uncover what's truly causing the physical aches and pains and the physical fatigue is when I have family members in the room. I'll give you guys just a few examples. I had a patient. She was in her 60s and came in. I saw she had come in 3 times before I came into the clinic. Always knee pain, back pain. And then I started to ask more questions. And I speak Spanish, actually, and I was asking questions, the typical questions that you guys as behavioral therapists taught me to ask about her history, about her work history, about how she sleeps. And she wasn't really answering them. And so I went through her daughter and asked her daughter, who speaks English and Spanish. So I would ask the question in English to her daughter, and her daughter would translate the questions to her in Spanish. And these questions about, do you worry about your children? Do you worry about your husband? Do you feel more anxious? All those questions, the answers to them that uncovered the underlying anxiety only came out when they were coming from her daughter, which I thought was really, really interesting. And I also, another quick example, I had a patient who developed facial scabies from when she was in a detention center in California. And I saw her for about 3 visits for the facial scabies. And on the 3rd visit, the scabies had resolved. She had a little bit of rosacea, so just like reddening of the skin that we wanted to treat. And she was so worried about this rosacea. And the redness in your skin, like from rosacea, yes, it's not the most beautiful thing, and it can be it's a cosmetic concern for a lot of patients, but it's not life-threatening, it's not serious, it has no other complications. And I spent a lot of time explaining this to her, but she was so concerned. At this visit, she came in with her daughter for the first time, and it was at this visit, after meeting her for 3 times, that her history came out, how she too had come in a detention center, was coming to seek asylum, had no idea where her husband was. Her daughter had suffered some pretty serious threats to her life while the family was in Mexico, and that's why they had sought asylum there. But it was only when she had someone there with her who had kind of understood what she had been through that she was able to open up to me as an outside provider, or as a third party. And so I think and I have countless examples of these patients that would have been through so much trauma, and even patients that haven't been through trauma, but patients that have underlying anxiety and depression because they come to this country and they work 6 out of 7 days a week for 8 to 10 hours a day, and they're just exhausted, and they're just spending all their time working and spending all their time worrying about their families and providing for their families. There's so much underlying anxiety that I see from those cases, and it's really been truly a learning experience for me to see that those only usually come out when they're accompanied by family members, or when I can find a piece of information to relate to about their experience. And for me, the only way that I know those questions to ask, or sometimes if a family member is there to kind of push me a little bit or suggest some things, or if sometimes when I have one of my medical assistants who are also Latino come in and, oh yeah, I know where he lives, oh, I know where he works, it's really hard, the boss there I've heard is terrible. And so it's those little cultural similarities and the little social awareness, it helps so much within this patient population. And so I wanted to present this to you because I think I can't provide a full scope of care to this patient population without the help of behavioral therapists. So the thing I wanted to pose to you guys is that I believe that in certain situations and for certain patients, that the use of these patients, Latino patients, the family is so important, and cultural and social understanding is so important, that third-party translators or third parties in the room may not be the best approach. That I think that having that the use of friends or even family members might be beneficial when providing certain types of therapy or counseling to these patients. Because I think what helps really is these patients come in with someone that they're already comfortable with. So someone that has an ongoing relationship and has knowledge of the patient's needs. And I really think that this helps this Latino patient population kind of open up, because there's been tons of studies that have shown that that health disparities exist in Hispanic populations, and that people believe the quality of health care is better delivered by a person of their own culture and by someone who understands their culture. And I mean, there just aren't enough Latino therapists out there. Like, we're a Latino organization, and we don't have any in our area. And so I think that this barrier can really be overcome by using family members, not necessarily even as translators, but having a family member accompanying the patient in the room. And then I think, since this is for you guys to learn more about treating Latino patient populations, I think really the key that I found in my practice is finding commonalities or finding ways to relate to them. And it's hard for sure, but I think if you just knowing a little bit about their culture, knowing what questions to ask, they really truly open up. And it's different than other patient populations that I worked with. I did my residency in Eastern North Carolina, that it was a mostly African American population. And granted, like I am Latina, like I'm from Brazil, so I can relate a little bit with these patients, but I still haven't had a lot of their same life challenges or been through a lot of the similar things as they have. And I was even more distant from the Eastern North Carolina African American population. But in Eastern North Carolina, it took me learning about the foods that they eat. And I actually went to a Southern Baptist church to see that kind of how they practice, to find little things to relate about. But even knowing those things in Eastern North Carolina, it took me almost half of my residency to figure out ways to relate to that patient population. Whereas with the Latino patient population, if you take a little bit of time to ask specific questions, if you're warm and use family members. They really open up to you. So I think these worries that we have about these health disparities in these Hispanic populations can really be overcome by uh, by by us as providers, by trying to really increase our social and cultural understanding. And again, I think that part of that can be overcome by using family members in the rooms in certain situations if the patient feels comfortable. I think that that's going to be incorporating families is a huge part of treating the Latino patient population. That was really it. I don't know. I guess we can open up to some questions, or we can wait. I know that our next presenter speaks specifically about translators, so I don't know. Does anyone want to speak up to see if we should wait or keep going?
We have about, I was going to leave 5 minutes for Q&A for each
Okay.
talk. So I think we have even a little bit more than 5. So if you want an open discussion or Q&A, we can start that.
Yeah, well, does anyone have any thoughts, any experiences they'd like to share?
I want to thank you for your insight, because I think it's great that you're thinking about this. I don't have an opinion of whether it's good or bad to involve family members. I think it's more about how to, and I think you're doing a fantastic job, because your results show that the way you are incorporating the family is a good way. The only other comment I have is I work many years in a Latino setting in the community. It was more with Puerto Rican families who are not immigrants. They are citizens. It's a different reality, a different, in every aspect of the family. I think there are many, many differences. The only thing I would say is that when we speak about Latino, we have so many, many different backgrounds and countries of origin that I'm sure you know this, that it's not the same to talk to somebody from El Salvador than from Nicaragua. So I always struggle with this concept of Latino because it's too broad. I'm just bringing it up, to open the conversation as well, like how sometimes it doesn't say much to say only Latino other than the sharing language. But I mostly want to thank you for what you said and how worried you are about doing it right.
And it's interesting that you bring that up, because I think part of the reason why I was offered this job is that the clinic director was like, "Oh, you're female Latina, you're gonna fit right in," and it to a certain extent. But like, I'm from Brazil, I know, and a lot of my patients are Mexican, and I've learned about that culture, and it is hard because when you have I think yesterday I had an El Salvadorian patient and I didn't know anything. And so, and their customs are totally different. And it's just really about being open and learning. But I appreciate you bringing that up, because it is very, very true. Anything else?
Yeah, Juliana. So, for those who don't know, we work in the same clinic, and what you've said really echoes with my experiences as well, especially working with Latino adolescents. I find I can have a lot better success when I have at least one parent in the room. So I think some of it is I get more information because I have the parent, but I see very quickly both the parent and adolescent are very, very open. For my part, I feel like I have more success whenever I'm very warm and welcoming, and that seems to help build rapport quickly, and I found I have had good success. So thank you.
Can you hear me?
Yes.
Oh, this is Jennifer Hodson, and I just want to know how we lost you out of Eastern North Carolina.
Well,
I am greatly mourning this, and I need to issue a complaint somewhere. So where were you at in Eastern North Carolina?
So I was at East Carolina University.
Yes.
And
So you were in my backyard. That's where I teach.
yeah,
Oh,
yeah. You
my
can
goodness.
launch a complaint to the GI department, and that's only because my boyfriend, he didn't match in GI there, so we ended up out here.
Oh my goodness, I'm so sad that we lost you, and just appreciate everything you said. We do a lot with Greene County Healthcare, which is, we have a large Latinx community and are trying so desperately hard to recruit Spanish-speaking therapists to this region. It's just very difficult, doing the best that we can, but feeling we appreciate what you said, and I am so sad for our loss.
Well, I do miss it there, and I really do, but I appreciate that. Thank you.
No problem. Well, come back anytime.
I will. Oh, you know, my parents are in Durham, so I may. We'll see. Any other questions?
I had a quick question for you.
Yeah.
So I appreciate your presentation, and as another fellow ECU grad, I say go Pirates.
Yeah.
So I had a question about workflow. Family-centered care can be difficult in primary care because a lot of patients come by themselves. And so I was curious, based on what you said about how you sometimes get more information because there are other family members present, does the clinic actively invite family members to come, or is it just based on whoever walks through the door? I was just curious if that's like an active part of the workflow.
It's not an active part of the workflow, and it is really based on kind of who walks through the door. I have asked patients to come in with the family member before if I have an unsuccessful visit, but it's not something. You're giving me great ideas that might be something the clinic does to encourage, like especially elderly patients, to come in with family members.
Yeah, I agree. I've had some success working with individuals. You can still do family-centered care with individuals, but having that other person in the room makes a big difference. It's hard to I guess make it a regular part of visits because it depends on people's schedules. But so I was just curious.
I know we have a few minutes until we're going to transition to Florencia. There was a comment in the chat box. I'll just throw to you, Juliana. Thank you for your commentary and your experience and for serving Latino Spanish-speaking families. I have also found that behavior change talk when a person centered on I as an individual is difficult. Helping females relating to Latina women as mothers and promoting behavior change talk through their role as a mother was helpful. In other words, motivation for change was high as it related to ability to care for others. That perhaps creates other difficulties too, but it was helpful to get the conversation or the ball rolling. Have you had that experience? And this is from Clarissa Aguilar.
Okay, so sorry, the experience of having.
And I don't know if she's still on the call or not.
Here, I can see it. No, I can see it. Okay.
Okay.
Yeah. Oh, yeah. Sorry. So I think it all goes back to finding a commonality. And I think if you can find something simple to relate to a patient, anything like this is a bracelet that I wear, and it's a lot of Mexican families or kids use it to bring good luck, and a patient gave this to me. But just this, I mean, it's a conversation starter, so it's a little bit of common ground that they understand, and that they trust you more. And I think when there is definitely just trying to read hers a little bit more. Yeah, so she's mentioning relating to patients as women or relating to patients as a parent, just any kind of any kind of similarity you can develop with your patient, I feel like it increases trust. And like I said before, I don't know, the Latino population is broad, but they're just so responsive to a little bit of extra care and a little bit of extra attention. It really is amazing, and it's very different than other patient populations that I've treated.
Yeah. Well, great. I want to keep the conversation going, but I know Florencia, if we want to give her the floor too. Thank you so much. I thought this was a great discussion, and I'm sure you may begin questions after this talk as well.
Okay, thank you.
Thanks so much. Well, why don't we transition over to Florencia?
Okay. So I'm going to unmute myself.
We can hear you. And if you have slides, I don't know if we could
I'm
share
going to. Let's see. If I go into that, and then so I have to share my screen, correct?
Correct. I think if you have that option.
Desktop. Oh, Microsoft Desktop. Here we go. Okay.
Perfect.
Everybody can see that?
All right. So we'll have about 20 minutes or so, give or take, with a little bit of Q&A at the end, and you're open whether you want questions during or wait until the end.
Okay. So does everybody just see the slide, or is it in weird presenter mode for you as well?
It's in presenter mode.
Okay. So, oops. How about that?
There you
go.
There
we go.
Excellent. Okay, great. So thanks again for having us. Do you go by Juliana or Juliana? I always ask. But either way, thank you so much for your wonderful presentation, but also for setting up what I hope to talk about for the next 20 minutes or so. So it's a great complement, a great pairing. So my name is Florencia Levinson-Chialvo. I'm a faculty member at University of San Diego. I'm a psychologist by training, and I train now MFT and counseling students here at the University of San Diego. And I should also, and I'll tell you a little bit about the focus of the training that we do here, and the work that I do here as it relates to what I'll be talking about today. But I also am an immigrant myself. I immigrated from Argentina as a young child. And so I think that also informs a lot of the work that I am interested in doing, and my positionality and my biases when I train our students. So I think that's important to share with all of you. So here in Southern California, and thank you, Juliana, for setting this up as well. Even before the current political climate and the situation kind of brewing in Southern to our south, both in Central America and in South America, we have a large Spanish-speaking population here in Southern California, but growing populations of Vietnamese speakers and Arabic speakers, especially those that are refugees or asylum seekers coming from the Middle East. And so something that we talk to our students a lot about are the challenges and also the benefits of working with linguistically diverse communities. But with doing that work, there can be a lot of challenges. We also train our students, a subset of our students, to work in integrated behavioral health. And so kind of where those two areas meet is kind of where I'm most interested in. How do we work with linguistically diverse communities in primary care specifically? So today I just want to talk to you briefly about, kind of give you a little overview about when we're talking about working with linguistically diverse communities, what are we talking about, why it's so important, that we recognize that this is a special population of folks that we see. And then today I'm just going to focus on working with interpreters and the do's and don'ts kind of doing that work. Okay. So I just wanted to provide a little bit of an overview in terms of who are we talking about when we're talking about linguistically diverse communities. So recent census data shows that about 65 million individuals in the United States speak another language apart from English in their home. And if we look at those, 41% of these individuals report speaking English less than very well, which is the current definition for for limited English proficiency. So that's a large portion, a subset of the population here in the United States. And when we're looking at what languages these individuals speak at home, Spanish by far is the largest, the most often spoken language in these homes, but we also see Chinese, Tagalog, Vietnamese, and Arabic kind of rounding out the top 5. But then it's important to recognize when we're talking about linguistically diverse communities, there's a very, very long list of languages and dialects that could be coming into the clinic. And recognizing that it can be very, very hard to find appropriate bilingual providers or interpreters to help us in that work. And sometimes it can take quite a lot of time to identify folks that can help you in providing kind of equitable care to these communities. And also when we're thinking about these communities and why their language needs and/or preferences are so important, is that it's been documented over and over again how these language needs, preferences, nativity status, so whether they were born in the U.S. Or in another country, how much that impacts both initial and continued access to quality healthcare. So this is in part due to the shortage of bilingual health providers that Juliana spoke to already. We just don't have enough bilingual providers across all professions to meet the needs of these communities. We also know that there's a stigma that specifically is related to being foreign-born or being part of an immigrant community that impacts both initial and continued access. And so and Juliana spoke to this already, but just to emphasize how, whether you were born here or elsewhere, how much that impacts your relationship with the healthcare system here in the United States. And then, family level barriers that have been documented, particularly when we're talking about healthcare for children. The immigration status of their family members. If the child might be born here in the United States and have citizenship, but if family members around that child have their immigration status is still up in the air, that can be a significant barrier to access for healthcare for that child. Here in San Diego, when all of the new policies were coming out after the election, we had lots of documented decreases in children. Children were being pulled from all sorts of things. Families felt like if their child was receiving lunches at school or breakfast preschool, that was going to put them on a list that then could flag them for ICE. So just that perception, and which was not true, was making family members very, very skittish about accessing care across the board. And then different preferences and expectations about what care will be all about, and that can create significant barriers for these populations. So I don't know how many, and I'm curious if I had the ability to take a poll right now, I would, but how many of you, if anybody wants to speak up, are aware of the CLAS Standards? Anybody want to say that they have a hand? Okay, good. Okay, and so I might be preaching to the choir, but I think it's important to go over this in case folks are not as familiar with them. So the CLAS Standards are the National Culturally and Linguistically Appropriate Services Standards. Were developed by the Office of Minority Health, the Center for Linguistic and Cultural Competency in Healthcare. And these are aspirational guidelines that fortunately is getting some traction in terms of states picking up the baton and thinking about legislative action to make sure that these now become law. but there's a lot of work to be done. But this is kind of in response to the health disparities that have been documented among linguistically diverse communities. And so what these standards state is that basically we should provide effective, equitable, understandable healthcare services that are responsive to cultural beliefs and practices, but also are provided in a patient's preferred language. And that's kind of the critical point. So when we're talking about the CLAS standards, what does that actually mean? What does that translate into in terms of what we should be doing? We should be offering language access to individuals at no cost to them. And I think this is something that some of our linguistically diverse communities aren't aware of, that it's not their responsibility, it's our responsibility to provide access to care in their preferred language. It's not their responsibility necessarily to identify a family member that can come in and do that. And if they request that of us, it's not like they're going to be charged more. So that's really important to make very clear. It's important for us to inform individuals of the availability of language assistance, and that needs to be done verbally and in writing, because we know that literacy rates fluctuate in these populations. And I think number 7 is one that's really kind of one of my buttons that I have that gets pushed often, is that we have to ensure the competency of individuals that are providing this language assistance. And I'll talk a little bit about maybe some caveats and some exceptions to this, but really, sometimes I hear, and I get this in my students that come through, they're like, oh yeah, no, I could probably provide care in Spanish. I'm like, okay, can you? Like, let's have a conversation and see how comfortable, because having a conversation at home with your abuelita, with your tias, that's a completely different level of fluency it helps you when you're trying to provide healthcare, but it is not the same thing as having a professional level, knowing the vocabulary, being familiar and feel fluent in that terminology to provide care. So very well-intentioned folks will say, "Oh, I can do that," but really, it's really important and critical that we assess the competency of those individuals to provide that care. And in signage, we need to provide signage as well in preferred languages. Okay. So let's talk a little bit about, so those are that's a pretty high bar, and that's why they're aspirational guidelines. But let's talk about when we're thinking for those providers, or because even myself as a Spanish language provider, I've worked with plenty of patients that are not Spanish speaking, and so I fall into the same category of, okay, I don't speak the preferred language of this individual or this family, and so what am I going to do to ideally live up to the CLAS standards? So then we need to rely on interpreters. So let's go over some basics. So this gets mixed up quite a lot. I fall into that. I fall into this sometimes as well. But when we're talking about translation is written translation. So if we need to take a handout that we have on, good healthy eating, we would rely on a translator to translate that into a different language. So we're talking about written material. When we're talking about oral communication, we're talking about interpretation. Okay? So if you're going to be calling up a service to get somebody to help you with an encounter, a clinical encounter, you are going to be requesting an interpreter. Okay? And interpretation can take the form of in person, so somebody that's actually in the room with you while you're doing that and providing that care. Then it can happen. Sorry, my screen as well. It can happen over the phone, which is always very interesting, but one way that can happen, and also video conferencing. So those are all the ways that you can engage an interpreter. So sometimes I get this question of like, well, how do I know when I need the services, or this patient or their family would benefit from having an interpreter? So the first and easiest way to know is that the patient or the caregiver or family member asks for one, but that doesn't necessarily happen all of the time. Again, for lots of the reasons that we talked about before. They think, oh, this is going to accrue more cost, or I'm not really entitled. I'm asking for something that I'm not entitled to. I'm making their work more difficult by asking for this. And any of the other things and other things have come up. They think that somehow they can they'll get flagged in some way if they request that. But some other ways, if they're not, they're like, oh no, we're okay. We don't need an interpreter. We can manage. There are some ways that you can go about trying to assess whether or not it would still be beneficial. So if you ask the patient or a caregiver a question that isn't a yes or no question, but requires a sentence response, like an open-ended kind of question, and they really struggle with providing you an answer, then that's usually a sign that an interpreter would be really helpful. The other way is basically you just have them repeat back to you what they heard you just say. And if they're not able to do that, then it's likely another sign that you could benefit, or they would benefit from an interpreter. And I think the most important thing we need to remember is that we have to normalize the use of interpreters and not make anybody feel bad about needing to use one. And I think part of that is taking it on us and say, oh my goodness, like this is more for me than for you. And so it's and that can go a long way of saying like, okay, fine, doctor, we'll do it because you would find it most helpful, and give them a little bit of an out, use our little strategy there. So this is what Juliana was talking about, and I'm so glad she brought it up. And we can hopefully have some good conversation around this. But when we're talking about using family members, some reasons why it's not ideal is that, like we talked about, are they really in a position to provide? Is there competency in language assistance where it needs to be? There could be a lot of errors that occur. They don't necessarily translate as is. Breach of confidentiality issues can be a problem. Patients don't necessarily, especially if there's a child in the room, a parent might not disclose important information that would be too sensitive for the child to know. And then unintended impact of personal relationships, if there is disclosure of information that maybe wouldn't be appropriate for a child to be aware of if a child is doing interpreting. And a reason for doing it is that, like Juliana talked about, is that there can be more trust and more familiarity that might be benefits and might be a reason why you would go down that road and use a family member or an MA or something like that in the clinic. So I know I'm running out of time, so I'm going to go kind of quickly. So ideally, if you were going to be working with interpreters, you would follow this kind of pre, during, and post these guidelines for pre, during, and post. So pre, you want to make sure, ideally, to try and meet, whether it's over the phone or in person, with the interpreter prior to the encounter. And you want to give them a heads up about basic information about the patient, things about important family members that might be participating in the encounter. Give them a little bit of background about why they're coming for the appointment, any technical terms, acronyms, or medications that might come up. And the reason why this is important is that medical interpreters, yes, a lot of them, that this is what they do for a living. They are familiar with a lot of terminology, but sometimes they still need to maybe look things up or make sure that they feel really prepared to go into the encounter and translate, and as they did interpret as is. You also want to remind them that they need to be doing interpretation as is. Sometimes people go a little rogue. During the encounter, you as the provider, you want to make sure that you're speaking directly to the patient and or the family members. The interpreter really should be speaking in first person, not he said, she said, or third person. You want to not speak too fast like I'm speaking right now, or too slow. Sometimes we think we need to, our pacing gets off because of interpreter being in the room. But we want to just kind of talk like we normally would with the patient. And we don't want to go on too long because we want to give the interpreter a chance to interpret and not forget what you just said, and then go into kind of kind of summarizing instead of interpreting as is. And we don't want to use abstract words or idioms, things that wouldn't have linguistic equivalency. And then after the encounter, this is the time that I think can be most beneficial, I think, for the provider, is that recognizing that interpreters are oftentimes really important, can provide you really important assessment and insights into the patient. So ask them about their impressions of a patient's fluency, the organization of their speech, their comprehension. They can provide that feedback to you. This is also a time for you to use the fact that they might be cultural brokers because they might have similar cultural background to the patient or the family members, and discuss the cultural factors that the interpreter might think have impact on that case or on that patient's health. And so this is, I think, where we can address kind of the cultural differences, but really seeing the interpreter as an asset in kind of navigating that. Really important to document. So if you use an interpreter, you need to include them by name in your documentation. If you go with a family member or a coworker, also document that. And it's important that we're documenting why we didn't use an interpreter. Because moving forward, that might be important. So I think I just want to say at the end, I'm happy to share these, but here are some references and some recommended resources. The last three I hyperlinked to like 1-2 pagers that can be used that talk a lot about what I talked about today. But if you want to share those with providers, lots of do's and don'ts of using interpreters. So I'm happy to take any questions.
All right. And Florencia, thank you so much. That was great. We have about 3 or 4 minutes for Q&A.
I know, I talk a lot.
No, you were great. I just want to make sure for the whole thing.
Oh, is there a chat? Oh, no.
Well, if I have a question about the students that you mentioned. So we have some students, and I'm in our inpatient setting right now where if there's no translator present, they'll say, well, I'm Spanish speaking. So if I can even talk a little bit, maybe that can join with patients. Are there kind of pros and cons to that? Because we want to give students the ability to work with families and patients that work better at this, but also if that backfires.
Yeah, I think it's tricky, and we have a lot of students that come to our program. I provide Spanish language supervision and training to them, and part of it is that they're trainees, so they need to be able to practice if that's something they want to build proficiency and competency around. So I think but I think it's also important to gauge what we're talking about. I share with students, it's important to check in with yourself and see where you're at. And really, patients are where, once we have a good foundation, that we need to practice. But if we're talking about a really big divide in terms of where you are and what you would need to be providing basic care, then there's other places that you can practice before you start practicing on real people. So I think it's just about checking with them and having an honest conversation about where they are kind of fluency wise, especially around professional vocabulary. Yeah. And I've worked with, I didn't talk about it, but I have a case that I worked with where it was a family who was coming up from Oaxaca, and they spoke Mixtec, and it was very, very hard to get an interpreter. It would take days for us to get an interpreter. And she felt, the mom felt that she could manage in Spanish. It wasn't her preferred language, but a secondary language that she could speak well enough. And so then I served as the interpreter there with the medical team. But that took a lot of conversation with her. Say, like, do you really feel like you're going to be able to understand everything I'm saying, or do you want to wait and we'll just get the Mixtec interpreter on the phone in 3 or 4 days? yeah, but sometimes you just have to do with what you have.
Thanks, that was helpful.
Florencia, I had a question about translators.
Uh-huh.
So we have some patient materials that we want to get translated into Spanish. And some of the people at the clinic have said, well, you know, we have some MAs or some other staff people here who speak Spanish, so they can translate it for you. And you know, after watching your great presentation, that doesn't seem like the best way to go. So how do we find good translators, especially in healthcare?
Yeah, I mean, it's not to say that MAs can't do it. I would say I would also want to advocate for the MAs and say, are they getting appropriate compensation? Because I think sometimes what happens with bilingual providers is that we get double the work because it's like, oh, you're not busy right now, right? You can come in and do this, or oh, you wouldn't mind doing this or that. And so we teach our students, you know, differential pay is a thing, and if you're going to be coming in with a skill set, you better be advocating for yourself to get additional pay. So I think if again your MAs feel like they are you know, and you have a way of verifying that they can do the job, there's no reason to make sure you're compensating them appropriately, either by taking other things off their plate. But I would say, you know, translating and then ideally back translating to assess, having one person translate it and then someone back translate it and then compare. That would be the ideal way of doing it, and then you can verify. I know healthcare systems, not all, but they're kind of moving towards, I know Baylor is doing this now. They have ways of, they basically have a test or an assessment that they do for their providers of all kinds to be designated or certified as either Spanish language providers. So also checking with your healthcare system to see if there's a way that they're certifying individuals, either like language fluency, whether written, some have written exams, some have oral exams, but you might be able to have certified folks within your healthcare system that you can reach out to and see if they would be able to do that work. That I think more and more we're going to see healthcare systems not just take people's word for it, but really kind of do their due diligence to make sure that their skills are up to par and they can provide competent care.
Great.
Thank you.
I want to be aware of time. Maybe we can fit one more question if the audience has anything. No takers. Going once, going twice. All right. Well, I do want to be aware of time. I know we went a little bit over, but Florencia and Juliana, thank you so much for this information. And again, I think both conversations, you know, there's a lot of threads and a lot of overlap was really beneficial. And not only these are going to be played back for video recording, but if either of you are open for people who have questions can email you or follow up for anything if you're open to that.
That'd be totally fine.
Okay.
Yeah, happy to do the same.
Okay. Wonderful. Well, thanks again. If this was 2 hours long, I'm sure we'd have a ton more questions and information as well too. But I think we'll wrap up for today, and some good words of wisdom for us as we get back in our clinical work this week. So thank you again. So yes, these will be posted. And just as a reminder, the next open call in May will be May 10th. Larry Mausch will be giving that talk. Just remember, send in your family center proposals to CFHA. You have 1 week left. Get them in. Drive the force for the mission, which I know you all will do very well. So other than that, I think we'll sign off for today. And I hope everyone has an awesome rest of the week. And thank you again for taking time out to be on the call and hear some great talks today. All right. Take care, everyone. We'll sign off.